Welcome to this video on the emergency management and critical care of anaphylaxis, presented by Dr. Nasser Hassan. Anaphylaxis is a serious, systemic, and life-threatening allergic reaction. It's a clinical diagnosis based on criteria, and treatment should begin immediately without waiting for lab confirmation. Pathophysiology involves a mast cell storm, leading to systemic degranulation and the release of mediators like histamine. This causes fluid shifts, distributive shock, and myocardial depression. Skin and mucosal symptoms are most frequent, seen in 90% of cases. However, 10% of cases present without skin findings, often indicating a more severe reaction. Gastrointestinal symptoms are also increasingly recognized as early signs of severe anaphylaxis. It's important to consider the differential diagnosis, or the mimics. These include conditions like vasovagal reaction, panic disorder, ASI angioedema, and scombroid poisoning, all of which have distinguishing features. Epinephrine is the first-line treatment and gold standard therapy. Delaying epinephrine is the #1 cause of death. It must be administered via the intramuscular route into the mid-anterolateral thigh. The empty ventricle phenomenon means always keep the patient supine with legs elevated, unless airway compromise necessitates sitting up slightly. Moving patients suddenly to an upright position can lead to fatal drops in venous return. Aggressive resuscitation includes IV fluids, high-flow oxygen for all patients, and continuous monitoring of ECG, BP, and pulse oximetry. Have a low threshold for early intubation. Second-line adjunctive therapies include antihistamines, corticosteroids, and bronchodilators. Remember, these do not treat airway obstruction or hypotension. For refractory shock, an IV epinephrine infusion is indicated if the patient does not respond to multiple IM doses. Glucagon is the rescue treatment for patients on beta blockers refractory to epinephrine. Biphasic reactions, which are recurrences without re-exposure, typically occur within 12 hours. Stable patients should be observed for a standard 4 to 6 hours, with the peak risk for recurrence at 12 hours. The discharge bundle is critical. Prescribe 2 doses of an autoinjector, provide direct training, include a 3-day course of prednisone and H1 blockers, a written allergy action plan, and referral for follow-up. For any questions regarding this video, please use the contact information provided. This slide lists the image sources used throughout this video.